So I think it is worth thinking about when and how to offer peer support. So starting with the first part is, how do we do this? What's the best way to structure a peer support program? So I think to have a successful peer support program, you need to have it very easy to access for someone who's identified as I'm suffering, I'd like some help. So that's called the reach in component. It has to be very easy. They have to know how to do it, that it's confidential, those sorts of parameters. But that said, when we first started this program years ago, when I was at Brigham and Women's Hospital, we had just the reach in component and nobody reached in. So we realized, of course, they didn't reach in because we hadn't changed the culture yet, and people were reluctant to seek help. So we added a reach out component. That is, when we knew about an event or any kind of stressor, like an error, like a patient aggression, like just a really sad outcome for patients, even when care was, absolutely beautiful. We then developed a way to assign a peer supporter to reach out to the peer and offer support. Now, why were we hesitant to do this in the first place? I'm sure you can imagine that we thought people would react in a way that was defensive. Why are you calling me? How did you know about this? And so it's very important when we train peer supporters to train them how to do that reach out in a way that doesn't generate that kind of reaction. And I'm always pleased and surprised that if it is offered correctly, which that's what the training is for, that people are very grateful, even if they don't want the support, are grateful that there is a program and that somebody has reached out and cares about them. So it's done in a very normalizing way, the reach out. The reason we have these programs is because I and every colleague I know has been involved in something like this event. And some of us find it really helpful to talk to a colleague. Is that something you'd like to do? So it really destigmatizes the reaching out. So the other question is, okay, for what kinds of events should we reach out? And I think, of course, errors, because they're particularly painful for us, but plenty of other things like, as I said, bad patient, just patient outcomes that are just sad. Things happen that are very sad to our patients. And on the opposite end of it, patient aggression. We're used to being trusted and respected, and it should be mutual respect. But there are some times when patients physically or verbally attack us, and it's very traumatic to have that happen. Any kind of investigation process is very traumatic. Again, being involved in a lawsuit, obviously traumatic. And I think the idea is talking to somebody who's been there, who understands, can be very, very reassuring. In the past, with a culture of silence, we've just sort of asked people to get on with things on their own. And, sometimes that works, but many times it doesn't.